Okay, so we should, for male, only one test is important. What is this? Semen analysis. Semen analysis, that is most one of the important test. So we should do, basically at first need to investigate the male. Basically one test, that is semen. And then investigation report we should evaluate. For usually what are the normal investigation report? We should see the volume of the semen, then spermatozoa count, morphology count, then any other abnormality of the spermatozoa. Suppose and there is so many terms. Azoospermia, that is absence of spermatozoa. Oligospermia, at least less than 20 million per ml. And morphology, abnormal size, shape, how much. Necrospermia means death of the spermatozoa. So many terms. We should go through the book. There is, you should know the different terms. So if one investigation is abnormal, we should repeatedly done every month, at least 3. Even on normal, after 1 month again we need to repeat. That repetition is important. So these are the about the semen analysis. And if we suspect any other cause from history, we should, suppose one patient come azoospermia, then need to, all through the hormonal assessment. Even like female, also male, there is hormonal factors also involved, like hyperprolactinemia, hypothyroidism, and hypogonadism. Also male are also affected. And now from history of the female and examination and evaluation, if you suspect there is irregular cycle and so many other factors, then we should evaluate the patient at first by ultrasonogram, and then hormonal study, and then others. Hormonal study, usually we do we should know the 5 hormones, that is especially FSH, LH, TSH, prolactin, and dihydroepiandrosterone sulfate or free testosterone, like this, 6. So FSH, LH, TSH, prolactin, DHS, and testosterone. These are the basic tests to evaluate the hormonal function of a woman. At what time we usually do this test? 2 to 5 days of the menstrual cycle. Within 2 to 5 days of the menstrual cycle. Okay. And regarding ovulation, what are the signs, symptoms of ovulation? You know, but what is the confirmatory test for ovulation? You know that. Progesterone level, 21st day, it is very, very important. 21st day of the menstrual cycle, level of the progesterone. That is more than 15 units at least. And other function, so many functions. Now we see corpus luteum presence, and like this, and then so these are the hormonal assessment we can do. And other investigation, suppose that is peritoneal factors. Peritoneal factors, you know, the ovum is released into the peritoneal cavity, and by the, like octopus function of the peritoneum and fallopian tube, fimbriated end, it is held by the fimbriated ends of the fallopian tube. What holds? Ovum. Ovum is entrapped by the fallopian tubes at the fimbrial ends. So the function between the peritoneal cavity, peritoneum, and fallopian tube is so important. One of the important is, the endometriosis. You know the term. Endometriosis is the commonest factor of the infertility, and it interferes the function between the peritoneum, ovum, and fallopian tube. And then pelvic adhesion. Pelvic adhesion also disturbs the function of the fallopian tube. And then fallopian tube itself is the problem when it is involved with the salpingitis, peritubal adhesion, and so many short tube like this. So anatomical any abnormality, it can affect the fertility. Okay. And you go now through the that is uterus. So uterine factors, the absence of the uterus, so not possible at all. Chromosomal factors, it also hypoplastic uterus, like it also affects the infertility, sometimes fibroid, large tumor which distorts the uterine cavity also affects the infertility, that is implantation, and so in this way there is a problem in the conception. Then sexual relationship also another factors. So how can we assess the tubal factors? That is so many assessment. Number one is ultrasonograph. Obviously, we can detect if it is salpingitis, hydrosalpinx, pyosalpinx, like this. We can assess by the ultrasonogram. Better transvaginal ultrasonogram is better. Another is what we know, the hysterosalpingogram. Hystero means uterus, salping means fallopian tube. So another invasive procedure is the hysterosalpingogram. We pass the dye usually just before the time of ovulation. Usually we do from 8th to 10th day of the menstrual cycle. Of the we pass some dye, contrast iodine usually use, pass through the cervix by the cervical cannula, and we by X-ray we see the pathway of the dye. It is passes through the fallopian tube or not. Spillage occurs through the ostium of the fallopian tube or not. So hysterosalpingogram, one of the procedure, invasive procedure to detect any problem in the uterine cavity or in the fallopian tube. Okay, that is blockage of the fallopian tube. If there is blockage in the fallopian tube, then no dye pass through the fallopian tube. There is no spillage through the fallopian tube into the pelvic cavity. So these are the, another is sonohysterogram. Sonohysterogram, by ultrasonographic guidance, we pass some normal saline into the uterine cavity and we observe that it is passes to the fallopian tube. Usually you cannot see, we assess by the collection of the fluid in the pouch of Douglas. So another is sonohysterogram. So hysterosalpingograph, another is sonohysterogram. Okay. Now these are the basic tests usually, and other test depends upon the evaluation of the patient. Now regarding management, what we do at first, the counseling of the couples. Counseling of the couples regarding the time of ovulation, regarding a sexual function, if any problem we should correct it. And then time given, newly couples we should give some times, as most of the couple conceive within 2 years. So at least we need to wait within 2 years if the age is less than 35 years. If more age, more obese, more endocrine disorder, and other operative intervention, the history of operative intervention, pelvic surgery, then what you do? We should need earlier treatment and management. As after 35 years, ovarian function gradually deteriorates. So we should not wait more in case of if the couples come to us more than 35 years. Now regarding management, if the patient needs correction of endocrine disorder, we should correct it. Suppose PCO, polycystic ovarian syndrome, there is no ovulation, there is maybe associated hypothyroidism, maybe hyperandrogenism, maybe associated with the hyperprolactinemia, so we should correct it. As hyperprolactinemia causes anovulation, so we should correct it, and hyperandrogenism also causes anovulation, so we should correct it, and then management accordingly. Then you should know the sign of the ovulation and the hormonal assessment of the ovulation. It is very important for the management of the patient.